May 9, 1945. Bergen-Belsen, Germany. One day after formal surrender, Dr. Heinrich Müller stood among 50 captured German medical personnel in a makeshift compound outside what had been, until 3 weeks ago, one of the most horrific concentration camps in the Nazi system. He expected execution, or at minimum, brutal treatment that would end in slow death from exposure, starvation, or disease. He had seen what liberation forces found in the camp: mountains of corpses, thousands of dying prisoners, evidence of systematic medical neglect that British medical officers were documenting with fury barely contained behind professional discipline. Müller had not worked at Bergen-Belsen. He had been Wehrmacht medical officer with army unit that surrendered nearby, swept up in mass capture of German military personnel flooding British custody. But he wore German uniform, had served Nazi regime for 6 years, had taken physician's oath, and then served military that committed atrocities his profession was supposed to prevent. When British medical officer entered compound that morning, Royal Army Medical Corps Captain, young, exhausted, face-carrying expression Müller couldn't immediately read. Every German doctor tensed, expecting judgment, retribution, the violence that captured SS personnel were already experiencing at hands of prisoners and guards, whose restraint had shattered upon witnessing camp conditions. The British captain looked at them for a long moment, then spoke words Müller would remember for remaining 50 years of his life. "Right. I don't care what you did, who you served, or what you believe. There are 15,000 people dying in that camp. We need every doctor we can get. You can help or you can rot here. Choose now." The liberation of Bergen-Belsen on April 15, 1945, by British 11th Armored Division, had revealed humanitarian catastrophe that exceeded even worst expectations of soldiers who had fought across Europe and thought they understood war's brutality. 60,000 prisoners remained in camp, 40,000 barely alive, diseased, starving, many too weak to move, many already dying from typhus, typhoid, tuberculosis, and simple starvation that medical intervention came too late to reverse. 10,000 corpses lay unburied, stacked in piles, scattered across camp, testimony to final collapse of camp administration in weeks before liberation. SS guards had fled or surrendered, leaving prisoners to die without food, water, medical care, or basic sanitation. British medical personnel arrived expecting to provide aid to concentration camp survivors. Instead, they encountered mass death event that overwhelmed every resource, every protocol, every assumption about what military medicine could accomplish. Standard field hospitals were designed for trauma casualties, wounds from combat, injuries requiring surgery and stabilization before evacuation to rear areas. Bergen-Belsen required mass epidemic response, long-term care for chronic malnutrition, treatment of diseases that British military medicine rarely encountered, and psychological management of survivors whose trauma exceeded anything medical training prepared doctors to address. Royal Army Medical Corps deployed every available medical officer, nurse, and orderly, requisitioned supplies from across British zone of occupation, established field hospitals in Wehrmacht barracks nearby, converted camp buildings into medical facilities, organized teams to bury dead before decomposition, created additional health hazards. But resources were desperately inadequate. 15,000 critically ill patients required individual assessment, diagnosis, treatment plans tailored to complex combinations of diseases and malnutrition. British medical personnel numbered in hundreds, working 18-hour days, triaging casualties knowing that many would die regardless of intervention, making impossible decisions about who received scarce resources like antibiotics, intravenous fluids, specialized care. Captain James Walsh had been medical officer with British forces since D-Day, treating combat casualties across France, Belgium, Germany, performing surgery under conditions that ranged from reasonably equipped field hospitals to aid stations under artillery fire. He understood mass casualties, understood working with insufficient resources, understood making hard choices about who could be saved and who couldn't. But Bergen-Belsen was different. Not sudden trauma from combat, but accumulated suffering from systematic neglect. Not casualties who might survive with proper treatment, but victims whose bodies had been destroyed over months or years of deliberate cruelty. And there were so many, too many for available medical personnel to treat effectively, even working to exhaustion. The decision to use captured German medical personnel was pragmatic rather than idealistic, born from desperate need for trained medical staff, not from philosophy about reconciliation or forgiveness. British commanders faced simple mathematics. 15,000 critically ill patients, perhaps 300 British medical personnel, including doctors, nurses, orderlies, and support staff. Ratio was unsustainable. Patients were dying not from lack of medicine, though supplies were insufficient, but from lack of medical attention. There weren't enough hands to feed patients too weak to feed themselves, to administer medications, to change dressings, to provide basic nursing care that prevented treatable complications from becoming fatal. Captured German medical personnel represented available resource. Wehrmacht units surrendering across British zone of occupation included doctors, medics, nurses who possessed training and experience relevant to crisis. Some had worked in military hospitals treating German casualties. Others had civilian medical backgrounds before conscription. All had taken oaths to heal, to serve patients regardless of circumstance, oaths that Nazi military service had corrupted but which professional identity might reactivate if opportunity existed. But using German medical personnel required confronting rage that British soldiers and medical staff felt toward nation that created Bergen-Belsen, toward regime that systematized atrocity, toward individuals who wore uniform of military that enabled genocide. Many British personnel opposed idea, argued that German doctors couldn't be trusted, that they might harm patients deliberately, that using them to treat Holocaust survivors was moral obscenity. Others argued from pragmatic necessity. Patients were dying preventably because there weren't enough medical personnel to provide care. Whatever German doctors had done or believed, they had skills that suffering people needed. Refusing to use those skills meant additional deaths that might be prevented. Walsh supported practical approach, not from forgiveness or belief that German medical personnel deserved opportunity for redemption, but from calculation that saving lives required using available resources regardless of personal feelings about their source. He had triaged too many casualties to let ideology prevent practical action that improved medical outcomes. If German doctors could reduce mortality, they should be used. Supervision would ensure they didn't harm patients. British personnel would maintain control, make decisions, oversee all treatment. German medical staff would work under direction, essentially as medical laborers whose training was valuable, even if their judgment and autonomy couldn't be trusted. This was the context in which Walsh entered the compound, holding captured German medical personnel, made offer that required them to choose between helping and waiting indefinitely in custody, whose duration and conditions were undefined. Miller's decision was instantaneous, except obviously because alternative was remaining in compound with no purpose, no activity, no contribution to anything meaningful, waiting for judgment that might never come, or might come as summary execution, that British military justice system was reportedly applying to SS personnel discovered among prisoners. But other German doctors hesitated, suspicious of offer that seemed too straightforward, worried about trap where acceptance of British authority might be used against them in future proceedings, concerned about working under former enemies who would supervise harshly, perhaps punitively. One older doctor, former professor from Munich Medical School, asked question others were thinking, what guarantee do we have of fair treatment, of protection from prisoner violence, of recognition under Geneva Convention as medical personnel entitled to professional status? Walsh's response was blunt. None. You're prisoners of war. You'll work under guard, under British supervision, following British medical protocols. You'll sleep in secured barracks, eat military rations, have no contact with civilian population. If you perform competently, you'll be treated as medical professionals. If you don't, you'll be returned to general prisoner population. Only guarantee I can offer is that if you help save lives, that will count in your favor when your cases are eventually reviewed. 28 German doctors, 12 nurses, and 10 medics accepted immediately, driven by professional calling, desire to be useful, pragmatic calculation that cooperation was optimal survival strategy, or genuine horror at camp conditions they had known existed abstractly but never witnessed concretely. Others refused, some from Nazi ideology that made working under British command unacceptable, some from fear that cooperation would be seen as betrayal by other Germans, some from simple exhaustion that made additional work psychologically impossible. Walsh took the 40 who volunteered, organized them into teams under British medical officer supervision, assigned them to specific wards with clear protocols. German personnel would provide basic care, feeding, washing, dressing changes, medication administration, under constant British oversight. They would not make diagnostic decisions, would not determine treatment plans, would not have independent authority over patients. They were essentially skilled medical orderlies rather than independent practitioners, their professional training valuable, but their judgment not trusted, their autonomy restricted by reality, that they remained enemy combatants whose defeat was measured in days rather than weeks. Miller was assigned to Ward 7, 60 female patients, survivors of camp's women's section, suffering from typhus, dysentery, tuberculosis, malnutrition so severe that basic physiology was disrupted, bodies consuming themselves because no external nutrition had been available for months. First day in Ward 7 confronted Miller with medical conditions he had never encountered despite 6 years of military service. Wehrmacht field medicine dealt with trauma, shrapnel wounds, bullet injuries, fractures, burns, conditions that were acute rather than chronic, that resulted from specific incidents rather than prolonged suffering. He had performed surgery under fire, amputated limbs destroyed beyond salvage, triaged mass casualty events where dozens of wounded arrived simultaneously, but he had never treated systematic starvation, never seen bodies reduced to skeletal remnants still technically alive, never managed diseases like typhus at epidemic scale, where transmission between patients required isolation protocols that limited resources couldn't adequately implement. British medical officer supervising Ward 7, Lieutenant Sarah Mitchell, civilian doctor from London who had volunteered for RAMC in 1942, briefed German medical team with efficiency that communicated both professional focus and barely suppressed anger. These women weigh between 30 and 40 kilograms. Their bodies have consumed muscle tissue, organ tissue, everything expendable for energy. They have no immune function. Any infection can kill them. Many have typhus, louse-borne, highly contagious, fatal without treatment, and often fatal even with treatment. We have limited sulfonamides, limited IV fluids, limited antibiotics. Triage is constant. Your job is basic care that keeps them comfortable, clean, fed as much as they can tolerate, and monitoring for complications that require doctor assessment. She demonstrated feeding technique. Patience required when patient's stomach had shrunk, when digestive system had shut down partially, when eating too much too fast could cause refeeding syndrome that killed through metabolic disruption, showed proper typhus precautions, delousing procedures, isolation protocols, personal protective measures that prevented medical staff from becoming disease vectors, explained wound care for pressure ulcers that developed when patients lay immobile for months, for injuries that had never received treatment, for bodies that healed slowly or not at all because malnutrition prevented normal tissue repair. Then came patient introductions. Not names initially. Many patients were too weak to speak. Some were comatose. Some had lost capacity for communication through trauma or disease. Mitchell introduced them by condition. Bed 1, typhus, advanced malnutrition, probable tuberculosis, maybe 3 days to live if we're lucky. Bed 2, dysentery, severe dehydration. We're trying IV fluids but veins are collapsed, maybe 20% chance of survival. Bed 3, the catalog continued. 60 patients, perhaps 20 who might survive with optimal care, perhaps 40 who would die regardless of intervention, all requiring attention, dignity, comfort in suffering that British and German medical staff would try to provide despite inadequate resources and overwhelming need. Work began with simple tasks that carried profound weight, bathing patients too weak to wash themselves. Miller had never performed such basic nursing care. Wehrmacht medical officers were surgeons, diagnosticians, treatment planners, not bedside nurses who handled bodily functions. But Mitchell's protocols were clear. Every patient would be cleaned daily, wounds dressed, bedding changed, dignity maintained regardless of medical prognosis. For patients dying from diseases medicine couldn't cure, cleanliness and comfort were only interventions remaining. Miller approached first patient, woman perhaps 30 years old, though malnutrition and disease made age estimation difficult. She watched him with expression that combined fear, suspicion, and exhaustion too profound for strong emotion. Mitchell supervised, correcting technique when Miller's inexperience showed, demonstrating how to turn patient without causing pain, how to clean wounds gently, how to speak reassuringly even when shared language didn't exist. Patient spoke Yiddish and Polish, Miller spoke German, but tone and gentleness communicated across linguistic barriers. Patient began crying, not from pain but from something else Miller couldn't initially understand. Mitchell explained quietly, First kindness she's experienced in months, maybe years. She doesn't understand why German is being gentle, thinks it's trick, thinks cruelty will follow. You need to be consistent, gentle every day, no variation, until she learns that this time it's different, that care is genuine even if it comes from person wearing uniform of people who did this to her. The psychological complexity was overwhelming. Miller was providing care to women who had suffered at hands of regime he served, wearing uniform that represented her oppressors, offering help that she had every reason to reject as manipulation or prelude to additional cruelty. And she was accepting, not trustingly but desperately, because she needed care regardless of who provided it, because survival instinct overrode every other consideration, because human bodies required attention that only trained medical personnel could provide. Day progressed through similar interactions, feeding patients who could barely swallow, administering medications under Mitchell's supervision, changing dressings on wounds that were infected, necrotic, resistant to treatment because immune systems couldn't fight infection, while simultaneously trying to prevent starvation death. One patient died during Miller's shift, woman in bed 14, typhus victim whose fever finally overwhelmed cardiovascular system too damaged to continue functioning. Mitchell pronounced death, made notes for documentation, directed German orderlies to prepare body for burial, moved immediately to next patient without pause for grief or reflection, because 15,000 other patients required attention and individual deaths, while tragic, couldn't stop workflow necessary for mass casualty management. Evening brought debriefing, Mitchell gathering German medical team, assessing their performance, addressing problems, planning next day's work. Her evaluation was clinical, professional, neither hostile nor friendly. You did adequate work. Some of you have clear medical training, some are less experienced. That's acceptable. We'll assign tasks according to capability. What's not acceptable is half-effort or resistance to protocols. These patients deserve best care we can provide, regardless of our personal feelings about who's providing it or who's receiving it. Then she addressed question Miller knew every German was thinking. I know what you're wondering. Why am I allowing Germans to treat Holocaust survivors? Why aren't I refusing to work with people who served regime that created this? She paused, expression showing exhaustion that went beyond physical fatigue. Because people are dying. Because I took oath to treat sick and injured regardless of who they are or where they came from. That oath doesn't expire because I'm angry. Doesn't become optional because I'm disgusted with what was done here. If you can help save lives, I'll work with you. If you can't or won't, you'll be removed. It's that simple. Miller raised hand, tentatively, unsure if questions were permitted. Mitchell nodded permission. How do you maintain professional distance? How do you treat patients without rage overwhelming medical judgment? Mitchell's laugh was bitter. I don't maintain distance. I'm furious every moment I'm here. Furious at what was done, furious that it happened, furious that medicine failed to prevent it because doctors like you, she looked directly at Miller, served system that did this. But I'm doctor first. Anger serves no one, doesn't help patients recover, doesn't bring back the dead, doesn't accomplish anything except making me less effective at work that needs doing. She dismissed them to barracks, secured building under guard, segregated from regular prisoner of war compounds, sleeping arrangements that were basic but adequate. Mueller lay awake on bunk, processing day that had transformed his understanding of what medical service meant. For 6 years he had treated German soldiers, comrades, fellow members of military serving shared cause, patients whose recovery served war effort he believed was justified. Now he was treating victims of that war effort, people who had suffered because of regime he served, patients whose survival was justice against system he had supported. The cognitive dissonance was devastating, but so was memory of woman in bed 1, crying at gentleness, accepting care despite every reason to reject it. That memory made sleep difficult and made morning return to Ward 7 necessary regardless of how he felt about it. Second week brought incremental progress, some patients stabilizing, beginning slow recovery that would take months or years to complete, bodies relearning how to digest food, immune systems recovering capacity to fight infections, minds processing trauma that no medical treatment could address directly. Other patients died, 3 in Ward 7 during second week, deaths that Mitchell documented meticulously, bodies that were buried in mass graves. British forces had dug using captured SS personnel as labor, adding to total that would eventually exceed 13,000 dead after liberation, victims of diseases and malnutrition, too advanced for medicine to reverse. Miller's relationship with patients evolved from pure medical transaction to something more complex. He learned names, those who could speak, those who were conscious and coherent enough to identify themselves, learned fragments of stories, where they came from, what happened to families, how they survived when so many died. One woman, Rachel, Polish Jew from Warsaw, survivor of ghetto and 3 concentration camps, asked him directly, "Why did you do this? Why did Germans do this?" Miller had no answer that wasn't either deflection or excuse. Tried to explain that he hadn't personally worked in camps, hadn't known specifics of what was happening, had served as military doctor believing he was supporting defensive war against enemies threatening Germany. Rachel listened, expression showing mixture of incomprehension and exhaustion. "You didn't know?" Everyone knew. Maybe not details, but everyone knew Jews were being taken, were disappearing, were dying. You chose not to know specifically because knowing specifically would require doing something, and doing something was dangerous. So you served, followed orders, treated soldiers who were fighting to defend system that was murdering us. And now you wash me, feed me, give me medicine, and think this balances, think this erases. Miller had no response. Because she was right. Ignorance had been willful, service had been complicity, and present care didn't balance past abdication of responsibility that medical ethics demanded. But he returned next day, and day after, continued providing care not because it achieved redemption, nothing could achieve that, but because patients needed treatment and he had skills to provide it. Mitchell noticed evolving dynamic, commented during debriefing, "Good, you're seeing them as people rather than patients. That's necessary, not for your conscience but for their recovery. They need to be treated as humans with dignity, not as medical cases or objects of pity. Your discomfort with that is appropriate. Your continuing to show up despite discomfort is what matters." Third week brought crisis. Typhus outbreak among medical staff. 3 British nurses infected despite precautions. Quarantined immediately to prevent further transmission, leaving gaps in coverage that made already inadequate staffing completely insufficient. Mitchell made decision that required command approval, but which she implemented immediately. German medical personnel would take greater responsibilities, would perform tasks previously reserved for British staff, would function as nurses and junior doctors rather than supervised orderlies. Risk was obvious. Giving enemy combatants greater autonomy, trusting them with patient care that could be sabotaged, relying on their professional ethics when systematic evidence suggested those ethics had been compromised by 6 years of serving regime that valued ideology over humanity. But alternatives were worse. Patients were dying from lack of care, not from untreatable diseases but from treatable complications that went unnoticed, from medication administration that was delayed, from basic nursing care that insufficient staff couldn't provide consistently. Mitchell briefed expanded German team. "You'll have more responsibility. You'll work with less supervision. You'll make decisions that British personnel would normally make. If you betray that trust, if you harm patients deliberately, if you provide inadequate care intentionally, if you use this opportunity for anything except saving lives, I will personally ensure you face maximum consequences British military justice allows. But if you work professionally, if you provide care comparable to what British staff would provide, you'll be saving lives that matter more than politics or history or anything except immediate medical need." Miller was assigned as acting medical officer for Ward 7, making rounds, assessing patients, adjusting treatment plans under Mitchell's periodic supervision rather than constant oversight. Responsibility was terrifying. For 6 years he had made medical decisions for German soldiers whose welfare served German military objectives. Now he was making decisions for Holocaust survivors whose survival was implicit repudiation of everything Nazi regime represented. One mistake, one medication error, one missed diagnosis, one delayed intervention, could kill patient who had survived years of deliberate cruelty only to die from medical negligence. First night working with expanded responsibility, Mueller stayed awake until 3 a.m. reviewing every patient in Ward 7, checking medication lists, verifying treatment plans, ensuring nothing was overlooked. Morning rounds revealed no crises, no deaths, no complications that couldn't be managed. Mitchell reviewed his work, found it adequate, moved him to rotation that had him supervising other German medical personnel who were taking on expanded roles. "You're competent," she said simply. "Keep being competent. That's all anyone can ask. Month after liberation brought visible progress, mortality rates declining as patients stabilized, as refeeding protocols showed results, as antibiotic treatments controlled infections that had been rampant. Ward 7 discharged first patient, woman who had recovered sufficiently to move to convalescent facility, who could walk with assistance, who weighed 45 kilograms instead of 32, who smiled weakly when leaving, thanked British and German staff without apparent distinction between former enemies and liberators. Her recovery was medical victory, evidence that effort was achieving results, proof that combination of resources and personnel, regardless of their nationality or history, could save lives when properly organized. But tensions remained. Some survivors refused treatment from German medical personnel, demanded only British care even when that meant delayed attention. Some German medical staff struggled psychologically with work that forced confrontation with regime's crimes, with victims whose suffering couldn't be rationalized or minimized, with moral complexity that simple narratives about following orders couldn't address. One German nurse broke down during shift, started crying while dressing wounds, couldn't continue, was removed from patient care, and returned to regular prisoner of war processing. Mitchell didn't condemn her. Some people can't handle this. That's human limitation, not moral failure. She tried, lasted longer than I expected, broke when confronted with things no medical training prepares you for. Miller didn't break. Came close. Nights when he couldn't sleep, when images of skeletal patients overwhelmed attempts at rest, when guilt about service to regime that created this paralyzed moral reasoning. But returned each morning, performed assigned duties, provided care that was technically competent and increasingly compassionate as patients transitioned from anonymous medical cases to individuals whose stories he knew, whose suffering he witnessed directly, whose recovery gave him purpose that Wehrmacht service never provided. Mitchell noticed evolution, commented during one of their increasingly frequent conversations, "You've changed. First day you were terrified of retribution, of patience, of being here. Now you're engaged, committed, almost like you're trying to atone." Müller considered, answered honestly, "I can't atone. Nothing I do here balances what was done, but I can help. That has to be enough because it's all that's available." Mitchell nodded slowly. "That's more self-awareness than most people achieve. Most doctors I work with still think medicine is pure, that our profession stayed clean while everything else got corrupted. You understand it didn't, that we failed catastrophically. That makes you more useful than doctors who think they're innocent because they didn't work in camps directly." June 1945 brought transition. Bergen-Belsen camp being closed as patients either recovered enough for transfer to displaced persons facilities or died from conditions too advanced for medical intervention to reverse. British military administration began planning for German medical personnel futures. Some would be retained for continued work in military hospitals treating displaced persons. Others would be processed through standard prisoner of war procedures. Others would face investigation for potential war crimes if evidence suggested direct involvement in Nazi medical atrocities. Müller expected investigation. Military doctor with Wehrmacht from 1939 to 1945. Participant in campaigns across Europe. Service that implicated him in regime's crimes even if he never directly participated in medical experimentation or euthanasia programs. Interview with British war crimes investigator was clinical, thorough, uncomfortable. Investigator reviewed Müller's service record, asked detailed questions about assignments, duties, knowledge of medical atrocities. Müller answered honestly. Easier because he had nothing to hide specifically. Harder because honesty required acknowledging that ignorance was choice, that serving military organization enabled regime's crimes even when individual doctor wasn't directly involved. Investigators' conclusion was documented in report that Müller would see years later. Dr. Müller served Wehrmacht in conventional medical capacity. No evidence of involvement in war crimes, medical experimentation, or euthanasia programs. His service enabled regime indirectly, as did all military service, but does not constitute criminal activity requiring prosecution. Recommend release to civilian internment with denazification proceedings. But before processing to civilian status, Müller was offered choice. Continue working as medical officer in British-administered displaced persons facilities, treating survivors who still needed long-term care, or accept immediate release to German civilian authorities for denazification. Mitchell advocated for first option. He's competent, patients accept him. He provides care that's genuinely helpful. We're short-staffed for months or years of work that remains. If he's willing and you approve it, I want him on staff. The practical recommendation outweighed considerations about propriety or symbolism. Displaced persons needed medical care. Trained doctors were scarce. Mueller had demonstrated capability and reliability over 2 months of supervised work. Mueller accepted, not from desire to delay denazification but from recognition that work was meaningful, that skills were useful, that helping survivors recover was contribution that mattered more than rapid return to civilian life in Germany that was devastated, occupied, facing years of reconstruction. He remained with British Medical Services until 1947, treating displaced persons, working alongside former enemies who became colleagues, if not quite friends, learning medicine that peacetime German training never taught him about treating trauma that was psychological and physical, individual and collective, recent and historical. 1947 brought release. Denazification proceedings classified Mueller as Mitläufer, follower, category for Germans who supported regime passively, but without active participation in crimes. Classification carried restrictions on professional practice, requirements for re-education, monitoring by occupation authorities, but allowed return to medical practice in civilian capacity, after appropriate retraining and certification that British authorities supervised. Mueller returned to Munich, worked initially under supervision of British medical administrators, eventually regained independent practice license, spent 40 years as general practitioner, treating ordinary patients with ordinary illnesses, nothing like Bergen-Belson's horrors, nothing that required moral reckoning about guilt and responsibility and complicity, but Bergen-Belsen experience shaped everything. Mueller never spoke about it publicly. Shame prevented that, sense that his role was too small to deserve attention, belief that story wasn't his to tell because real heroes were British medical personnel who liberated camp and survivors who endured suffering he merely witnessed aftermath of. But privately, with medical students he trained in later years, with colleagues who asked about wartime service, he described work that taught him what medicine meant, not technical competence or diagnostic brilliance, but service to patients regardless of who they were, where they came from, what history they carried. One story he told frequently: Rachel, Polish survivor who asked why Germans did this, who accepted his care despite having every reason to refuse it, who recovered over months from near death to health that allowed emigration to Palestine in 1946. She thanked me when she left, Mueller would say. I told her I didn't deserve thanks, that I should apologize. She said, "You didn't do this to me. Others wearing your uniform did this. You washed me, fed me, helped me live when I should have died. That matters more than uniform." I don't know if she was right, if present help balances past complicity, but I know her survival mattered. Know my small role in achieving it was only good thing I did in years of serving regime that destroyed everything medicine is supposed to protect. The complexity never resolved. Guilt and purpose, complicity and contribution, past abdication and present service. Mueller carried all of it through decades of civilian practice, through retirement in 1987, through final years watching Germany reunified, watching Europe transformed, watching history debate meanings of war he participated in, from position that was neither heroic nor criminal but uncomfortably in between, guilty of serving evil system, credited with helping victims of that system, never fully either perpetrator or rescuer, but something more complicated that simple narratives couldn't. Capture. The true significance of Bergen-Belsen medical collaboration transcended individual stories of German doctors and British officers working together, represented fundamental question about how societies rebuild after atrocity, whether guilt is permanent and collective, excluding all Germans from participation in reconstruction, or whether individual responsibility can be assessed, allowing some Germans who served regime to contribute to repair of damage their service enabled. British decision to use German medical personnel wasn't forgiveness or absolution, was pragmatic choice made under desperate circumstances where saving lives required using available resources regardless of their source or history. But pragmatic choice had moral implications. By allowing German doctors to treat Holocaust survivors, British implicitly acknowledged that medical ethics could transcend national and historical divisions, that physicians' obligation to patient existed independent of politics and ideology, that healing was possible even between victims and representatives of oppressor regime. This wasn't triumph of universal humanism over particular justice. German doctors who committed medical crimes were prosecuted, regime was dismantled, Nazi ideology was condemned. But it was recognition that not all Germans were equally guilty, that some who served regime did so in ways that were complicit, but not criminal. That reconstruction required German participation because alternatives, permanent occupation, complete exclusion of all Germans from civil society, were neither practical nor sustainable. For survivors, acceptance of German medical care was equally complex choice. Some refused, couldn't accept treatment from people wearing uniform of their oppressors, needed to maintain distinction between liberators and defeated enemy, required clear moral categories that German medical participation confused. Others accepted, desperately needing care regardless of provider's nationality, recognizing that survival required setting aside rage and suspicion, pragmatically choosing life over ideological purity. Neither response was wrong. Both reflected trauma that shaped everything, that made simple decisions agonizingly difficult, that required survivors to make choices no one should have to make about accepting help from representatives of regime that tried to exterminate them. British medical personnel like Mitchell navigated impossible position, wanting justice for crimes committed, wanting Germans punished for what was done, but also needing German medical expertise to save lives, recognizing that denying care to survivors because using German doctors was symbolically uncomfortable meant allowing additional deaths that could be prevented. Her choice, to work with German medical personnel while maintaining supervision and accountability, reflected tension between justice and necessity, between moral clarity and practical requirements of mass casualty response that exceeded available resources. The collaboration wasn't redemption story, was compromise story, everyone involved making imperfect choices under terrible circumstances, achieving results that mattered even when they came with moral costs that couldn't be fully resolved. Heinrich Müller died in 1995 at age 78, 50 years after Bergen-Belsen, 48 years after release from British custody, decades of civilian medical practice behind him. His obituary in Munich newspaper mentioned Wehrmacht service briefly, noted post-war career, said nothing about Bergen-Belsen because he had never spoken publicly about experience that shaped everything that followed. His family found documents after his death, British service records, letters from Mitchell written in 1960s when she researched Bergen-Belsen history for a medical journal article, photographs of Ward 7 that Müller had kept despite distressing memories they triggered. Most striking document was letter Müller wrote but never sent, addressed to Rachel, Polish survivor who thanked him despite his uniform, who recovered and emigrated and lived, according to post-war records Müller had somehow obtained, until 1989 in Israel, raising children, working as teacher, building life that Nazi regime tried to prevent. Letter was attempt at apology, acknowledging complicity, explaining, but not excusing service to regime, describing how her survival gave him purpose that Wehrmacht service never had. It ended, "I cannot know if you remember German doctor who washed you, fed you, helped you recover. Perhaps you don't. Perhaps those weeks were blur of pain and recovery where individual caregivers were indistinguishable. But I remember you. Remember your question. Why did Germans do this? Remember that I had no answer then and have none now. Remember that you accepted care despite having every reason to refuse it, and that acceptance taught me more about humanity than 6 years of medical service to regime that destroyed humanity." Bergen-Belsen collaboration demonstrated that medicine could function across divides that seemed unbridgeable, that professional ethics could survive political catastrophe if practitioners chose to prioritize patient care over ideology. That healing was possible even in context of historical trauma that made trust nearly impossible. Wasn't guarantee that similar collaboration would succeed in every circumstance. Worked at Bergen-Belsen because British maintained control, because supervision prevented abuse, because desperate need for medical personnel outweighed concerns about using former enemy combatants, but demonstrated that under right circumstances, with appropriate safeguards, former enemies could work together for shared purpose that transcended history and politics. The ward where Müller worked was dismantled in 1946. Building returned to German administration, eventually demolished during post-war reconstruction. But principles it represented, that medical ethics transcend nationality, that healing requires resources from any ethical source, that humanity persists even in aftermath of inhumanity, remained relevant across decades when societies struggled to recover from conflicts that shattered trust and required impossible choices about reconciliation, justice, and practical necessities of rebuilding. Fear of retribution transformed into opportunity for service. Enemies became colleagues, if not friends, and lives were saved that might have been lost if pragmatism hadn't overcome ideology, long enough for medicine to function as it should, treating patients who need care, regardless of everything except their suffering and their humanity.